things should always end with a bang, and Taral is the right person to start light the fuse so as to get a good explosion at the end. So we have we have a boy who's got a lateral condylar non-union on the left side. He had a fracture 4 months back, operated with some K-wire fixation, and then the wire was removed, and then he presented to us with this kind of a X-ray.
So, from the audience, let's take a voting poll. How many of you feel that this fracture is still healing up and there is chance if you put in a plaster, it will do well? Just raise your hands. And how many of you feel that this will not heal, requires something to be done? Can anybody from the audience tell me what would you do at this stage? From the audience, anybody?
Please, you just have to come up to the mic and say something.
Yeah, the person in front in white shirt, yeah. What would you do at this stage? What?
We'll redo it. We'll open and curatize the area between and we'll fix it.
Fix?
Yes.
Osteosynthesis, is that the word you're looking for? Osteosynthesis,
Yes.
Right, osteosynthesis. Yeah. So we'll ask Dr. Agashe. Dr. Agashe, what would be your line of management?
I'd like to examine him clinically. Obviously, my final aim would be osteosynthesis.
Yes.
But before...
Clinically, sir, he's shown that there is
He's got
very
movement
restricted
at
range
that
of
side.
movement.
He doesn't have full movement. I think I have a video to show you.
Stiff elbow, sir.
Yeah.
Stiff elbow. Yeah. Please show the movements. So there is a flexion deformity and just, 10 degrees movement.
Okay.
Probably it is from the fracture, probably it is from a previous surgery and scarring or prolonged immobilization. This is the status.
So as I said, my final aim will be osteosynthesis. I like to counsel the parents that A, it needs surgery. B, the range of movement may not be complete when we even after surgery.
Why do you say that, sir? Well, what is your doubt in that getting the range?
He may not get a full range of movement basically because of contractures.
He may get functional range of movement.
He'll get
You will
a
of course say
functional
that
range of
functional
movement.
range.
He'll get a functional range of movement.
So the question here is what comes first, the egg or the hen? Would you, mobilize this patient, therapy, get range of movement and then fix, or fix first and do arthrolysis and then do physiotherapy?
I will fix, do arthrolysis and then aim for movement. Reason is here, the movement, whatever you gain, maybe at the non-union site, and you would just think that you are gaining range of movement, number one. Number two, without a good fulcrum, you will not be able to get good movement. So I'll first fix and then work on that.
All right.
There is
Arshad,
a
go ahead.
bone anteriorly, so whether it is a myositis or some displaced fragment. And loss of movement is disproportionate to the fracture.
So what ossification you see, it's also on the medial side.
Yeah,
So it's likely that this patient must have had, whenever you have injury on the lateral side, there is also an unseen injury on the medial side, which we don't see on the x-rays, but if you feel at the initial presentation, there will always be a tenderness. So this must be a pull, from the medial collateral ligament, which has caused ossification, possibly.
There are
medial
two
structures.
ossification centers. One is here and one is anteriorly also.
Yeah, so it's the same one which is seen on APL. Go ahead, Harshad, show us what did you do?
So I have the next, what I have done post-operatively is I've open reduced it, cleared the area of fibrous tissue on the lateral side. There was the fragment was rotated, not completely rotated, but it was malaligned. I aligned it, put in a stabilizing wire and then a screw which will cause compression. This is what I got post-operative.
Did you graft this as well?
No, there was no primary grafting done. Just compression after clearing the raw bony surfaces, not going inside the joint.
Second question is, did you completely, clear this fragment, mobilize it and then fix it?
The fragment was cleared wherever it was required for the bone to bone to have contact, and in the joint where I needed to derotate it to put it back in place.
One of the, sort of a scare in our minds while dealing a fracture like this is avascular necrosis. And we want to know, how did you prevent AVN from occurring in this?
Yeah, so I went by the posterolateral approach. I approached the fragment from the posterior side, tried to reduce my soft tissue dissection in the anterior surface, tried and get it as closely aligned as possible and passed in the wire. Though it is known that an anterior approach is a better approach because vascularity is posteriorly. I did it from the posterior side because the access was a little better and I could get this alignment.
One question to Dr. Kakatkar. In a case like this, sir, is it easy to identify which is the fracture surface, what is the articular surface? In an old case, which has been already operated, how do you really go about dissecting and seeing what is your cue? What are the tricks?
Well, at the end of 4 months, it is very difficult to identify exactly the fracture surface because everything has become very smooth. So one has to really get oriented, and one of the guidelines that you can use is the articular surface.
Absolutely. So articular surface is your guideline. First, identify the articular surface because the rest everything appears the same. Second trick here is you may not be able to get absolutely anatomical reduction. In that case, it's imperative to get anatomical reduction of the articular surface. Sometimes there will be a gap on the lateral margin, on the metaphysis, and you may be having to ready to graft this and keep the graft area ready. In case if you have not kept a graft area ready by mistake, always upper end of ulna is available to graft lateral condyles. So please remember that upper metaphyseal ulna, God has gifted it with a very wide sort of area and good cancellous bones. So utilize it in case if you have not prepared this in any of the cases.
So Taral, my question again to you and the panel is that up to what months would you want to fix it and after what point would you say this is probably not going to heal up?
So in fact, the lateral condyle fracture non-unions fall into two categories. One is fixable and which according to me are up to 6 months. After 6 months what happens is, they will be mobile non-unions and the problem is cubitus valgus. And in those we, either fix in situ but we don't go for dissecting it and fixing it anatomically. But it doesn't mean that at 5 months and 29 days you will fix and 6 months and 1 day you will not. So these are gray areas and you will have to use your clinical judgment. I want to say here a sort of a line from Rockwood Green's book that lateral condyle ununited after 3 months is a nightmare fracture. And even a experienced pediatric elbow surgeon will find it difficult to operate these fractures. So Harshad, we have to be very careful, gentle and do it with utmost care. Take an experienced person with you when doing this case. Just show us what was the result.
Taral, I have a question. If the patient comes after 1 or 2 years, because of tardy ulnar palsy late coming, you do fix or you wait for that to happen, then you do the osteotomy or do something?
If patient comes late, then we do everything together. And it depends on what the problem is. If the problem is deformity, you correct the deformity. If additional problem is tardy ulnar palsy, you do transposition. If the problem is instability, you also fix the fragment in situ. So it all depends on what is the problem, and you solve those problems which are the sequelae of non-union rather than actually treating non-union in those patients.
Hello, sir. There is a question.
Can I ask you a question?
Yeah, please.
As you said that you can take a ulna graft and you can put it. Exactly how will you do the grafting? Can you, in short, describe?
So we'll come to your case and that time we'll discuss.
Okay.
So can I ask a question?
Yeah.
So one question.
Yeah, go ahead, sir. Show us the long-term result, how the patient.
Yeah. Dr. Ashok, I want to know what was, the first operation was done open or it was a closed, and what was wrong? Why it happened?
First surgery was just a KY fixation, which was done elsewhere. It was not opened, it was a closed KY fixation. And when the patient came to us, he came to us with a non-union.
Means it was a bad reduction or it was a...
Sir, we don't have the x-rays. I don't have the x-rays because the wires were removed already when he came to us.
So just Harshad, Sandeep is ready with his case, but you can show us the result.
This is what happened at the end of 1 year. The patient was, of course, not from Bombay. He was from UP. And I could... where's the video? There's a video showing range of movement.
Just play that.
Yeah. No.
It's gone blind. So, but I've seen the video, and Harshad, this video is showing excellent range of movement.